Hi, everybody. Welcome. Come in, come in. Karen Hobbs here. Please don't let that put you off. I promise I'm a lovely Karen. I hope everybody that knows me through Probably Nothing can attest to that. Come in, welcome. If you're watching on catch up after we've filmed this, thanks for catching up. Thanks for taking time to tune in to the Eve Appeals live chat show, Probably Nothing. As I said, my name is Karen. I'm the very proud and excitable host of Probably Nothing. And Probably Nothing has actually been running for, I think it's almost 3 years now. We started in June 2020. This is Series 8, Episode 1 of Series 8. So hello, made it to Series 8. Yay. We started Probably Nothing, as I said, June 2020. And we wanted to create a space where we could put out really clear information, where I talk to experts, talk to people with lived experiences of the 5 gynae cancers, and address specific issues, specific symptoms, risks, causes of the 5 gynecological cancers: womb, ovarian, cervical, vulval, and vaginal. So over the last 7 series, we've covered lots of different subjects: screening, changes to your vulva, menopause, hereditary risks, you name it, we've talked about it. And Series 8 is inspired by a project we've been working on with the North East London Cancer Alliance. It's called You Need to Know, and the aim of it is to give womb cancer awareness, the symptoms of womb cancer, get that message across to people from the Black and Asian communities. And all of this came from research showing that in 2018, people from the Black and Asian communities were much more likely to be diagnosed with a stage 4 womb cancer rather than a stage 1 womb cancer. So stage 1 is early, stage 4 is the last stage of cancer. There is no stage 5. And so it really showed that, combined with the fact that Black women are more likely to be diagnosed with womb cancer, really showed that there's a kind of gap in knowledge and something we can do to proactively get information out there. So that's the project we've been working on. So we thought, why not dedicate a whole series of Probably Nothing to speaking about womb cancer, specifically within Black and Asian communities. So I'm going to welcome my guest now, who is, she's absolutely everywhere. She's beauty, she's brains. We always send each other bitchy messages on Instagram. So I don't mind just being really like, oh, here she is, bring her in. It is the wonderful, in highly demand, absolutely beautiful, amazing, incredible Dr Aziza Sesay, who is an NHS GP and women's health ambassador. I'm just kind of jealous of her, but also love her at the same time. So here we are. I'm so happy to have you. Thank you for coming on to talk to me.
Thank you so much for having me. And that is the nicest you've ever been to me.
I bet people listening are like, what has she been like before, if that was good? Oh, it's been bad, people. It's been bad.
No, we have such a great relationship.
We do, don't we?
Karen. So knowledgeable.
My darling, can you just give us a little bit of an introduction to who you are and why we're chatting today?
Okay, thank you so much. Well, I am Dr. Aziza Sesay, as Karen very kindly mentioned. I'm an NHS GP, a GP educator. I'm an honorary senior clinical lecturer. I'm also a host, a speaker, and a health content creator. So I run the platform called Talks with Dr. Sesay, which is all about health education, awareness, advocacy. And I have such a strong passion about this, particularly about women's and gynecological health. And I have a very strong affinity for Eve Appeal, because I think that their work is groundbreaking, necessary, and life-saving. And that's why I'm here. I'm really excited to be part of Probably Nothing. I've been wanting to be on for the longest time. And this is a topic that's very close to my heart. So let's get going.
Let's get into it. Okay, so I mentioned at the beginning, I'm going to be talking about womb cancer. So if people don't know, womb cancer is the most common of the 5 gynecological cancers. Aziza, can you just tell us, what is womb cancer? What does that mean? Are there different names for it? Give us the top line.
Of course. So I brought my favorite little prop to help us with this quick gynae anatomy lesson. This is the internal gynecological anatomy. Those are your ovaries. This area is the hot spot at the moment. That's the womb. Oh, the mirroring. Okay, that's the womb. This is the cervix, which is I need to look. This is the neck of the womb. This is the vagina. And that is the vulva, which is on the outside. Okay, so when we talk about womb cancer, it basically is cancer of the womb, so that area. But it does have other names. So you might have heard it being called uterine cancer, which is uterus, uterine. So that's the other word for womb, or endometrial cancer. So the endometrium is here. That is the lining of the womb, and essentially it's the area that thickens every single month for women and people who menstruate. Anyone who menstruates every month, once a month, this area thickens in preparation for fertilized egg. And if that doesn't happen, then it sheds, and that's what comes out as period blood. So the endometrial lining is where cancer often starts, and it's often called endometrial cancer. So as Karen said, it is actually the most common of all the gynecological cancer. And actually in the UK, about almost 10,000 women are diagnosed with womb cancer every single year. So it's extremely common. And the thing is, not many people are even aware of what womb cancer is. You always hear about cervical cancer, and then people think, oh, I've gone for my cervical screening, it was negative, so I can't have womb cancer. So it's really important to know that cervical screening has nothing to do with womb cancer. And also, it's the fourth most commonly occurring cancer in women in the UK. And it most commonly occurs in women who have gone through menopause. So when we say menopause, we mean that they've stopped bleeding completely for 12 consecutive months. That means that they've gone through menopause, no more bleed. Those are the individuals who are at higher risk. However, it's important to remember that it can happen at any age.
Of course. And so we're going to speak like a bit about symptoms and risk factors, and then pathway to your GP if you're concerned. So you mentioned that most commonly it occurs in people that are post-menopause. So I think the average age is about 51 for that in the UK, isn't it? But of course, we know that anything can happen to anybody at any age. And one of the kind of really sort of driving factors of us doing this sort of project in this series is that, as we said, most cases occur after menopause, but also the kind of, there's never a good thing when it comes to cancer because it's cancer, but often with womb cancer in postmenopause, about 80 to 90% of people that have a postmenopausal womb cancer will have symptoms. So that's why we think, right, we can get in there early and tell people about the symptoms. So Aziza, can you take us through, if somebody is premenopausal and postmenopausal, so still having periods, finished having periods, what could potential womb cancer symptoms be, please?
Okay, so if you're someone who is still having periods, okay, now the potential symptom we always talk about is abnormal vaginal bleeding. So when I say abnormal vaginal bleeding, I mean that's bleeding in between your periods, or bleeding during or after intercourse, or bleeding really significantly heavily. And if you are past menopause, you shouldn't be bleeding at all. Okay,
nothing at all.
Nothing at all. And it's so important to emphasize this point, because some people think, and I think you say this often, I love that you say this, some people think that having bleeding after menopause could be the final bleed. That is not the case. If you are bleeding after menopause, please just get checked out. I mean, as we say, and we'll say this a few times, it doesn't mean that you have uterine or womb cancer 100%, but it's always better to get checked out, because early detection saves lives. So yes, so abnormal vaginal bleeding, or if you notice a change in your vaginal discharge, so if there's blood in the discharge, or it's pink or black, or anything that's different for you. In women who are bleeding, who are having periods, it's really, really important to know your cycle and understand your cycle. It's so important to know your body, period, but know what your cycle is usually like. So has it changed? Has it become longer? Has it become more painful? Has it become heavier? Those are all potential symptoms that are associated. Also, if you notice an abdominal lump, or severe abdominal pain, if you're getting pain during intercourse, if you have pain in your lower back or your hips, if you have blood in your urine, those are all potential symptoms that are associated with menopause. Womb cancer.
Don't write everybody off just yet. And it's really interesting that you mentioned the discharge, because I think a lot of people, so we bang on about abnormal vaginal bleeding. We're going to mention it loads. It's all we're going to talk about. But it's the key sign of womb cancer and cervical and vaginal cancer. But so many people, and I would, if I didn't work for Eve, would think that abnormal bleeding means bright red blood, or like a really bright, heavy red period. Like you said, it can be just a tiny bit of coloured discharge, right? Just like a little bit of pink or red or brown.
Absolutely. So it's again why it's important that you do keep an eye on things, notice what your discharge is like, even if it's the tiniest bit of blood in it. If you don't expect that, that's never happened before, get it checked out. Understand your body, understand what your discharge is like. We know that the discharge can change throughout the month. Like shortly before, shortly after your period, you might notice like you're getting sort of brownish. But if it's happening on odd occasions, and again, if it's different to what's your usual, just get it checked out just in case.
So if someone's, say, like 35 years old and they notice they're not on any contraception, and they notice that 4 days before they get their actual period every month, there's a bit of brownish discharge. If they notice that that's actually every single month, and if they think about it, it has been for a while, that's likely to be normal for them, right? Because it's like a regular pattern. It's obviously linked to hormones because it's the same time every month. But when something happens outside of this, that's when we need people to come and see their Aziza, their GP, right?
Yes, please, we want to see you're not wasting our time. Please.
What would you say to someone that, because when we talk about things like ovarian cancer, we often talk about when symptoms persist. You know, if you have persistent bloating, please go to your doctor. What would you say with regards to the abnormal bleeding and womb cancer? Like, does it have to be every time I have sex there's blood? Or what if it's just one time? What if it's my mum who's in her 70s, she gets one bit of pink discharge? Like, does it have to be persistent?
No, that's the difference with the womb cancer compared to, say, ovarian, where we often say if it persists for about 3 weeks. If this is abnormal and it's not your normal, it doesn't happen for you, you've never had this before, just get it checked out. It's better to be safe than sorry. We see you, we assess you, and then hopefully we rule out cancer. But if it is cancer, it means that we picked it up early, which is where cancer is more likely to be treated. The treatment will be more likely to be curative, successful, and less invasive.
And what would you say, because I know I get these questions when I've been doing the talks with the lovely, I don't know if they're watching, they're probably busy, but the North East London Cancer Alliance, if they happen to be glued to their computer screen, woo, we love you. But we've had this question a few times. You know, we talk about if you bleed after the menopause, if you have abnormal bleeding pre-menopause, get checked out. But we've had the valid question, and I'm sure people watching will be thinking the same. Like, when you're going through menopause, your bleeding is like, for it can be years. You know, you can get a period, not get a period. You think, oh, I've gone through menopause. Oh no, I actually haven't. It can take years to go through it. So how can someone that's, say, 49, 50 and their periods and bleeding is all over the place because their hormones are changing and going through this period, how can they truly know when something is abnormal, you know, and not just part of their menopause transition?
It's really difficult, and that's a really good question. So I think sometimes it's good to understand terminology. So oftentimes people say menopause is the perimenopausal time, but actually perimenopause is the period that lasts long. So that's the period before menopause, when the hormones are sort of all over the place and you're having all these odd bleeding, and you get a period, you don't get a period, and so on. But when we say menopause, that is defined as you have not bled at all for 12 consecutive months. If you haven't bled at all for 12 consecutive months, even if it's one day after that and you start bleeding, that's abnormal. Please get it checked out just in case. Now, if you are in between those stages, it's really difficult to know, because it's to know whether it's abnormal or not. But I would just say trust your gut. And if you're finding that, okay, no, actually this is persisting, where I'm bleeding and spotting on these odd occasions where that wasn't the case before, just get it checked out. If in doubt, honestly, get checked out, literally.
And we talked about the symptoms of womb cancer, but are there risk factors or things that make someone more likely? We spoke about Black women being more likely than other ethnicities to get womb cancer, but is it just ethnicity? Are there other things that come into play?
Yeah, so there are multiple different things, but what I want you to remember is that womb cancer is very strongly associated with estrogen, high level of estrogen. And that's because when I mentioned to you earlier about the endometrial lining, it feeds off of estrogen. So anything that increases the estrogen level, which is a sex hormone that's often produced by the ovaries, but it can be produced by other parts of the body as well, that increases the risk of womb cancer. So things like obesity, that is the strongest risk factor of womb cancer. And that's because fat cells can release and secrete estrogen. So that increases the risk. Also, as we mentioned, older women are at higher risk. So postmenopausal women. If you are on synthetic estrogen, so for instance, if you're on HRT, hormone replacement therapy, that can increase your risk. And that's why usually they give you another hormone called progesterone, which acts as a protective factor. So it doesn't allow for the endometrial lining to thicken, essentially. So it's protective in that regard.
Also, I was going to, sorry, just to interrupt, only because you touched on HRT. There's been, I know we spoke about this earlier, like there's been, when we were getting ready for the session, there's been a lot of talk in the news the last couple of days about HRT and, you know, what's going on. Does it cause cancer? Does it not? But it's all about balancing the estrogen, right?
Absolutely. Yeah. It's about balancing the estrogen. And also, I mean, we know that yesterday the RCOG, RCGP, BMS, I'm just saying all these letters, but essentially faculties have come together.
XYZ, everybody. But everybody really did say.
Yes, they did come out to essentially release a joint statement to basically say that it's important that women who are requiring treatment be managed safely with established guidelines that are set out by NICE, MHRA, and the national international guidance. So the guidance is that we aim to give the lowest effective dose that controls the symptoms. And we need to ensure that we do things, and this is in general, though, it has to be very patient-centered with the person who's in front of us. And also we need to ensure that we give all the information to the patient so they're completely aware of the medication that they're being given, the dose that they're being given, why that dose is being given, and so on and so forth. So I think maybe we need to sort of calm down because the title of the article was quite inflammatory.
It causes a lot of fear, doesn't it? When people see headlines like that.
It does. But there's been a lot of research and evidence, and as long as we stick to guidelines, and if guidelines are sort of not followed, there has to be a reason behind it. And again, the patient needs to be informed. There has to be informed consent, so they're aware of the risks associated.
So we've covered estrogen as a risk factor, unopposed or unbalanced or excess estrogen, and that and the link to obesity. We have done other kind of whole episodes on Lynch syndrome, but just a quick talk for people. There is a genetic condition called Lynch syndrome. If it's in your family, you're at a higher risk of having womb cancer, amongst other cancers, bowel included. But only about 4% of womb cancers are caused by Lynch syndrome, right? So it's not like if you have Lynch syndrome in your family, you're definitely going to get womb cancer. You're just at a higher risk. So if anyone's watching and they think, I've got a strong family history of womb and or bowel cancer, speak to your doctor and we can see about genetic testing. So that is also a factor. I'm just
there's also diabetes, PCOS, and having your periods start earlier at an earlier age, and also periods that when your periods stop at a later age, so menopause at a later age, all those things can increase the risk as well.
So like menstruating for a longer
pretty much
period of time. Okay. And now can we talk about the link between womb cancer and ethnicity? And I said at the beginning, Black women are more likely to be diagnosed with a womb cancer. Do we know why yet? Like why are you more likely to get womb cancer than me?
I know, it's really scary.
I'm sorry, that's very aggressive. Sorry. Why?
No.
This was a good visual aid, but now I realise I'm just like diagnosing you. I mean, there's
no.
Hopefully
it's not ever going to happen, but it's the truth. That's the truth. That's the reality, and that's why it's quite scary. And again, that's why I'm really passionate about it. The reality is, so there was a study that was released earlier this year with Cancer Research UK and NHS Digital, where essentially they have found that Black women are more likely to be diagnosed at a late stage of multiple cancers, not just womb, but also breast, colon, ovarian, you name it, everything. And they don't quite understand why either, but there are suggestions which include things like they did a survey with YouGov, Cancer Research UK, and they found that Black women were most likely to report that they didn't know what the signs and symptoms of cancer was. So that's a big thing. Lack of awareness is such a big thing. And you don't know what you don't know. So if you didn't know that abnormal bleeding was part of womb cancer, why would you come forward?
Why would you go to the doctor if you just bled a bit?
Exactly. Especially as a woman where you're bleeding for majority of your life. So there's that, but there's also the aspect of lack of representation. So often if you look at ads and anything to do with womb cancer, and this is why I really admire Eva Peel, you do not see Black or, you know, ethnic minority faces. Often it is a white woman. So, you know, if I'm someone who isn't aware, you just assume that, oh, that's not a disease that affects me. So representation is really, really key. And there's also socioeconomic factors. So again, on the survey, they said that Black women were more likely to report that they were concerned about what the tests would do, how it would affect their pay, you know, and their income, and whether they'll need further tests, that kind of thing. But also, we know that unfortunately the wait times for gynecological appointments are so long, and some people are managing to get things done privately, where they're getting investigated privately, and that's speeding up the process. If you don't have the income, then it's unlikely that you'll be able to do that. So that's another factor.
So there are lots of knock-on factors rather than just because you are Black. It's everything else that comes with that. Yeah.
But now one that is because I'm Black is the fact that we are 3 to 5 times more likely to have conditions like fibroids.
Yeah, I read about this.
Yeah. So fibroids are essentially
get the tool out. I knew that was coming back up. I was like, where is it? She turned to the side. I was like, I know what's coming up next.
They are essentially non-cancerous growth that happen in the muscular layer of the womb, and they can cause really severe, heavy, painful bleeding. So similar symptoms to having womb cancer, right? So it might well be that some women just think, oh, well, you know, it's just part of my conditions, part of my fibroids, and so they won't attend. And that's a big deal. And I think also us as clinicians might again make that mistake where we put down patient symptoms to that, and again delays their treatment, delays their investigation and their diagnoses. Then there are language barriers that come to play, and also stigma and embarrassment. So I have to be honest, within my community, but not even just my community, women's health, gynecological health, there's a lot of taboo, there's a lot of embarrassment. People don't want to come forward because of it. They don't know how to talk about it. They don't want to talk about it. So that's a big thing. But we also need to, I have to mention the fact that there are systemic racism elements that come into play, and there are patients who may not want to go in because they've had unpleasant experiences because of racism, or they just felt like they weren't listened to. So why would I go to my doctor? So these are all little things. Well, they're not little; they're actually big things that attribute.
And there's I was reading when I was looking into this that kind of people have been told, Black women have been told, like, or maybe their pain hasn't been taken as seriously. And there's that real stereotype, isn't there, of like a Black woman is strong and can handle a lot, and that kind of whole stereotype. So it's like you'll be seen to be able to handle pain more than I can, so it's not taken as seriously, right?
Yeah. Sorry about that.
No, yes, I can't even hear anything. I don't know what you're saying. Are you saying sorry for being a Black woman or sorry for something else? I don't know where we've gone.
Never sorry about that.
I was like, do not be sorry for that. There's someone in the room. Okay, I'm with you. I'm with you.
But no, I agree. That's a really important point, that strong Black woman narrative. And we do that to ourselves as well, where it's as women in general, but also as Black women, we're like, no, we don't want to complain. We don't, we're stronger than this, and it's fine. It's part of being a woman. Those sort of narratives need to change, because they can, shorten people's lives.
Of course. Yeah. There's no weakness in coming forward and saying, can I just speak to you about something that I'm concerned about? Right. It doesn't mean you're any less strong or anything like that. So in terms of, I'm just conscious of the time, we've got a few minutes left. I'd like to end this with kind of a section talking through if someone either pre-menopause but particularly post-menopause, because of the sort of theme of the series, if someone comes to you with post-menopausal bleeding, what happens? Like, what can they expect to happen with you? how would you advise someone prepares for this type of appointment? What can they expect next? Yeah, what happens?
Yeah, no. So first of all, I'd say thank you so much for coming. This is really good. Great.
That's the nicest GP greeting ever. Like, thank you so much.
I do say that generally,
Yeah,
but genuinely. But essentially, yes. Thanks for coming. And then we would talk through your symptoms. What exactly is happening? When did your symptoms start? How long have you had them? How have they progressed? How have they changed? And this is where it's really, really handy to have a diary of your symptoms written down, like just so you know the pattern. I know we said make sure you go in and get seen right away, but I appreciate that sometimes it can take a week or so before you can get an appointment with a GP. In that time, write down what's been happening so that we could talk through and we can assess what could potentially be going on. We then would talk you through what medications you're taking that could be attributing to your symptoms. Also, we find out what your individual risks are. Talk about the risk factors that we've been talking about. So do you have a family history? Do you have a personal history of cancer? So have you had bowel cancer before, ovarian cancer? Do you have a family history of either of those? And then we would discuss any other associated symptoms. So are you getting any abdominal pain? Are you having any back pain, hip pain? Are you have you noticed any change in your vaginal discharge? That kind of thing. Any other symptoms that could be associated. And then we also assess whether or not you have any other underlying conditions, again, that could be attributing and that could increase your risk of having womb cancer. And then we'd examine you. So often that would just involve us, feeling around your tummy, seeing if there are any lumps or anything palpable to feel. Sometimes we would do what's called a speculum. So we'd insert it so we can have a look inside just to see if there's any source of bleeding. And sometimes we take some swabs to find out whether or not there's an infection that could, again, be causing the bleeding. But usually we would recommend that you have tests done, which include an ultrasound scan. So that's where, just like having a baby, they have a scan to see your womb. And essentially what they are measuring is the lining of the womb, just to see how thick it is. And if it's over a certain size or certain thickness, I think it's about 4.5, then we would refer you to the specialist. Regardless, if you have postmenopausal bleeding, we would refer you under what's called the 2-week wait pathway, which is where you get seen urgently by the specialist team, the gynecologist. So yeah, the ultrasound scan, if it's more than 4.5 centimeters, you would have a procedure that's called a hysteroscopy, which is where essentially they insert a telescope that has a camera and a light at the top of it. And they insert it through your vagina, through the cervix, and have a look inside the womb just to see if there's any abnormal changes, to find if there are any lumps or polyps, as we say. And they can take biopsies as well. And then it's through the biopsy usually that they can diagnose whether or not it's cancerous. But that's essentially what happens. And majority of the times it is benign. So it's not cancerous. So I don't want you to think that, oh my God, my doctor's referred me for a 2-week wait, I have cancer.
This is it. Yeah.
It doesn't mean it's cancer, but it's always best to get checked out.
Always best to get checked. And one final question. So you said, regardless of, what else is going on, if someone post-menopause has abnormal bleeding, you would refer. Do you always need to see your patient face to face? Or if I phoned up and said, hi, Aziza, we've got a telephone appointment. I'm 65 and I've got some vaginal bleeding. Would you say, oh, come in, Karen? Or would you refer me based on what I've told you over the phone? Because I'm thinking for people that, can only get a telephone appointment for a few weeks or something.
Yeah, no, that's a really good question, actually, especially with the current state. So yes, for me, red flags immediately. That's what we call a red flag symptom. Red flag symptom is a symptom associated with cancer. I would refer you. I may say, okay, look, actually I have an appointment. If I have an urgent appointment available, I have an appointment available. I'll see you in a day or two. But regardless, that referral will be sent through based off of what you discussed.
Yes, perfect. You, as always, have answered everything so perfectly, so beautifully, with smile, humor, brains, everything. I just love you so much. You're just that. Yeah, I love and hate you at the same time.
I love you more.
Where can people? Oh no, it's not possible. Can people find you on social media? It's at Talks with Dr Sesay, right?
Yes, absolutely.
Yes, great.
On all socials.
She's got great educational content on there. So please, if you ever want to see health information broken down in a way that is actually understandable, follow Dr. Aziza. I'll say goodbye to you backstage in a second. So go away for now and I'll say bye to you in a second. Bye. Thank you so much. Oh, I love her so much. Thank you so much to everybody that's watched this live. Thank you so much to everybody that's going to watch this on catch up. I hope you found the first episode of Series 8 of Probably Nothing all about the symptoms, risk factors of wound cancer, particularly amongst Black and Asian women. I hope you found that helpful and informative. Next week on Tuesday, the 11th of April, I'm going to be speaking to Dr. Ayushi Panda, who is a gynecologist, and we're going to be going that one step after you've seen Dr. Sesay with your symptoms. We're going to be talking about what happens once you get that referral appointment for potential wound cancer symptoms. So do tune in next week, Tuesday, 11th of April at 5:30 for Probably Nothing, episode 2 of Series 8. Thanks so much for watching. See you soon. Bye-bye.